Okay, you are called to the labor room that one of your junior has delivered a grand multi-para, and after the delivery of the baby, along with the delivery of the placenta, she felt that there is a bulge-like mass coming out of the vagina. She called you to the labor room, and she is asking for help. And how would you proceed? Okay, so first of all, I will make sure that I will do the proper examination to make sure that it is a uterine inversion. But then once a uterine inversion is confirmed, then I will call for help. I will call the all my junior colleagues and the consultant on call for help, and I will call for help of the senior midwife who is in the labor room, and also the staff nurses in order to pass the cannula and take the essential blood. So I will first of all assess the airway. I will maintain the level of the consciousness by maintaining the airway. Then I will just evaluate the breathing, and for that I will give the 100% oxygen by mask or the bag mask. Then I will ensure that the circulation is appropriate. Usually there is a patient is usually in this shock, so I will ask the staff nurse to insert the wide bore IV cannula 14 gauge on both sides, and then send the blood for full blood count 4 unit, and for cross match and the clotting, and give warm crystalline IV as rapidly as possible. Then I will give atropine of 300 to 600 microgram IV if the heart rate is less than 60 per minute, and I will establish the monitoring of the pulse, blood pressure, urine output via catheter. Then I will establish the adequate analgesia and call for the senior help if available. Then if the syntocinon is running, then I will stop it. Okay, then I will attempt the manual replacement as soon as possible, and for that I will just gently push the fundus back through the cervix. If the placenta is still attached, then I will leave it. And for that, first of all, I will make sure that the uterine relaxation has been given. Okay, so I will ask the staff nurse to give 250 microgram of terbutaline subcutaneously, or 2 sprays of the GTN sublingually, or glycerol trinitrate IV, or general anesthesia may be required in such case in the form of halothane. Okay, so if my attempt of manual removal is successful, especially after giving the uterine relaxation therapy, then once reduced, I will maintain hand in the uterine cavity until a firm contraction occurs and IV oxygen is being given. Then remove the placenta, and I will explore the cavity gently for any sort of the trauma. But if my attempt of manual removal is unsuccessful, then I will go for the hydrostatic replacement, which is also called Augie and Ida method, in which I will get 2 to 5 liters of the warm normal saline and attach the giving set onto elastic ventouse cup, and I will prime the system and then place the ventouse in the vagina and run the fluid under the gravity from the height of 2 meters, maintaining a cell manually at the introitus, and the reduction is usually achieved in approximately 10 minutes. If it fails in less than 3% of the cases, which occurs in less than 3% of the cases, I will go for the laparotomy. So the surgical intervention may be via vaginal approach or the abdominal approach. Through vaginal approach, we have the spinal operation or the Costner operation. In the abdominal approach include the Huntington and Howelton approach. So in the vaginal approach, spinally operation will be preferred, in which involve the dissection of the bladder from the inverted uterus. The midline split is made in the cervix and is clearly separated from the bladder. Then the anterior wall of the everted uterus is split by the pressure with the index finger and thumb. The uterus is turned outside in, and the myometrium is reapproximated with the 2 layers of running absorbable suture. The vaginal skin is reapproximated with interrupted suture and is the full thickness of the cervix. The Kussner operation involves the opening of the posterior cul-de-sac, the incision of the cervix and posterior wall of the uterus. Thumb pressure along the side of the uterus produces reversion. Interrupted sutures are used to close the incision, and then I will do the closure of the colpotomy. The next approach approach would that be the abdominal approach, which is performed either by Huntington procedure or by Haveltine procedure. In Huntington procedure, laparotomy is performed to locate the cup or funnel of the uterus formed due to inversion. I will dilate the constricting cervical ring digitally. Then I will stepwise do the digital traction is required in an upward direction after placing the clamp or ring or Alice forceps in the cup of inversion below the cervical ring or around the ligaments. Repeated clamping and traction must be continued until the inversion is corrected. The next is that of the Haveltine procedure, in which the longitudinal inseam is made posteriorly through the cervix, relieving the constriction ring and allowing the traction on the round ligament and repositioning of the uterus and subsequent repair of the inseam, which is closed in the two-layer. The new abdominal uterus preserving approach at laparotomy, bladder is dissected off the cervix, enter the vagina by the longitudinal inseam. Two finger pass through the inseam above the intravaginated uterine body and exerting counter pressure with the other hand, and inversion can be reversed. The hysterectomy as a last resort if the life is at threat because PPH, sepsis and family is completed. The complications include PPH more as compared to shock than the maternal death, endometrial sloughing, damage to the intestine and the uterine appendages, and pulmonary embolism. The differential diagnosis include UV prolapse of the uterine tumor, that is polypoidal growth, gestation trophoblastic disease, occult genital disease, marked uterine atony, and undiagnosed second twins.